Good evening, all our members of Maharashtra Ophthalmological Society, and especially all our young stars, our young residents who are joining us from the nooks and corners of the state, and many of them who are joining us also from across the country. On behalf of Maharashtra Ophthalmological Society, me, Dr. Vardhaman Kankriya, would like to welcome you as the chairperson of the scientific committee. And as you all know that we have been having these postgraduate programs every month, 2 times in a month. Every month has been curated for one specialty. And this month is very special because it is one of my favorite specialty, which is actually neuro-ophthalmology. We all know that neuro-ophthalmology works like mathematics. There is a lot of diagnostic dilemmas, a lot of interesting trivias. And during the postgraduate times, for I think many residents, this is one of the most intriguing specialty. Many times we actually do not have the full exposure of this specialty in our residency, and that's why we have some of our best teachers from across the country who are going to teach you. And the first one of them being Dr. Rashmin Gandhi, sir, who is joining us from Hyderabad. He has been one of my first teachers when I was in Shankar. Along with that, we are very lucky to have our MOS faculty, the expert in this field, Dr. Hemalini Samant. So I would like to welcome also her to this forum. We are lucky to have our experts, Dr. Ashwin Sainani and also Dr. Karandikar ma'am, who are going to deliberate and actually give pearls to our residents. And happy to have Madhvi moderate this session, who has been a very young, dynamic neuro-ophthalmologist trained in the US. Of course, we are very, very thankful to our own Dr. Sumit Lahane, who has been instrumental in curating and coordinating this PG webinars month after month very, very meticulously. And I would like to, before I go further to invite our president, I would like to wish each and everyone who is joining us today a very happy Teachers' Day. This is a great day for us to have this webinar, especially on the postgraduate forum. So over to our president, our guiding light, Dr. Santosh Agarwal sir, who has been instrumental in guiding us very strongly and also giving us the right direction this year. And over to Dr. Agarwal sir for his presidential address.
Yeah. Thank you, Dr. Vardhaman, for your kind words. Good evening, everyone. At the outset, I wish you a very happy Teachers' Day today on the eve of this Teachers' Day. I also welcome all the speakers, mentors, Dr. Ashwin Senani, Dr. Sumita Karandikar, Dr. Rashmin, who is my good friend from the SN days, Dr. Hemalini, and especially I thank Sumit for curating these PG webinars from the very beginning of this year. And also I invite Dr. Madhvi Bijlani, Dr. Saili and Dr. Sneha. Best wishes for their case presentation. I thank all PGs who are attending today's webinar because neuro-ophthalmology, I think it is a little complex field and difficult to understand many times. And many times private practitioners, especially, they don't indulge in the details of the neuro-ophthalmology. So for PGs, for as far as examination is concerned, you should know the details or basics of this neuro-ophthalmology. It's really interesting, but there are very few mentors across the country. Dr. Rashmi, Dr. Hemalini, who are spearheading this field, and we are lucky to have them in our today's webinar. Definitely, you people are very lucky to have such a stalwarts in our webinar who can guide us, who can unfold the mysteries of this neuro-ophthalmology. So thank you, everyone. My special quote is today's quote is teachers, about the teachers only. Teachers motivate, fuel our passion, and shape our life. We should always respect our teachers who are the real heroes of our life. Happy Teachers' Day. Thank you very much for giving me this opportunity. Thank you very much.
Thank you very much, sir. Very well said. Teachers are truly our heroes and role models. So now I would like to invite Dr. Sumit, who has been the main coordinator for our PG programs, to take it further, please. Thank you.
Thank you, Adaman sir. Good evening, everyone, and happy Teachers Day to everyone. Here, it's my shared luck that all the faculty involved here are directly, indirectly my teachers in ophthalmology in various fields. And I'm lucky to have this webinar on the day of Teachers Day today. So I would be thanking MOS for providing this platform and having this teacher-student relationship ongoing throughout the year, and basically utilizing this platform to connect with all the postgraduates all over the Maharashtra. I would like to thank here Dr. Madhvi Bijlani, my dear friend, and who is a neuro-ophthalmologist, presently assistant professor at Nair Medical College. She is a alumni of NKP Salve Nagpur Medical College, and she has done her fellowship in pediatric ophthalmology and neuro-ophthalmology from Arvindai Hospital, followed by Michigan University. She is very keen and very active member of Pediatric and Neuro-Ophthalm Society, and I thank Dr. Madhvi for being here, and I hand over the show to Dr. Madhvi for the introduction and the beginning. Dr. Madhvi, over to you.
Hi, good evening, everyone. Thank you, Dr. Sumit, for the kind introduction, and very happy Teachers' Day to everyone present here. I'll just quickly introduce the panel before we dive into the case discussion. Our first PG presenting today will be Dr. Sneha Punjabi, who is a resident at DY Patil Medical College, Navi Mumbai. She's been mentored by Dr. Sumita Karandikar, who is the professor and HOD of the ophthalmology department there. Ma'am takes a keen interest in PG teaching and academic activities and has over 20 years of experience in the same. Our second PG is Dr. Saili Shah, who is a resident at Hinduja Hospital. She has been mentored by Dr. Ashwin Senani, who's a practicing pediatric and neuro-ophthalmologist trained at Arvindai Hospital, Madurai, which has also been my alma mater. And he's also done fellowships in the UK and Australia and is currently a consultant at Hinduja and Wadia hospitals. Our panelists today are Dr. Himalini Samant, who is also a pediatric and neuro-ophthalmologist in Mumbai. She's been trained at Shankar Nethralaya and is the director of the Eye Associates. She's a passionate teacher, and we are very grateful that she has agreed to spend time with us today. And also joining us shortly will be Dr. Ashwin Gandhi, who is practicing in Hyderabad, and he really doesn't need much introduction. We've all heard his lectures throughout the COVID period, and we'll wait for him to join us in a while. So let's start with Dr. Sneha Punjabi. Could you please share your screen, Sneha?
Yes, ma'am. I'll just do that. Is my screen visible, ma'am?
Yes, yes. You can start whenever you're ready, Sneha.
Is my screen visible, ma'am?
Yes, we can see it. You can go to slideshow mode and start.
Yeah. Yes, ma'am. Good evening, everyone. And this is my case presentation. I'm mentored by Dr. Sumita Karandikar, and I'm a postgraduate final year resident at Dr. D.Y. Patil School of Medicine, Navi Mumbai. My patient, a 35-year-old male patient, came to ophthalmology OPD with chief complaints of diminution of vision in his left eye since 4 to 5 days. Patient was apparently all right 5 days back when he started experiencing sudden onset painless diminution of vision in his left eye, which was progressive over a period of 5 days. There was no history of spectacle usage in the past, no history of any ocular trauma, ocular surgery, or any allergies, no history of headache, periocular or retroorbital pain, nausea or vomiting, no history of loss of consciousness or blackouts, no history of transient attacks of blurring of vision, no history of flashes of floaters, and no past history of use of any eye drops for any known eye disease. In the past history, patient gives history of similar episodes of Patient gives history of similar episodes of vision loss twice in the past, in 2012 and 2013, for which, as per patient informed us, he was started on certain injections followed by oral medications, which eventually led him to certain problem with his hip, which led him to hip replacement surgery a few years back. Patient also claims to have a reduced vision in his right eye since nearly 5 to 6 years. Patient here also gives us a positive history of tuberculosis in the year 2019, for which he was on treatment for 6 months, and he claims to have completed his treatment effectively. There are no other systemic illnesses in the past and no significant family history was given. Personal history was insignificant with normal bowel bladder habits and a mixed diet consumption. No history of alcohol, tobacco smoking, or IV drug abuse. In the general examination, patient was conscious, coherent, cooperative, and hemodynamically and vitally stable. The rest of the systemic examination was well within normal limits. CNS examination and cranial nerve examination was well within normal limits. In the ocular examination, there was normal head posture, orthophoric, no facial asymmetry. In the ocular examination, in the right eye, the visual acuity taken by the Snellen's chart was finger counting at 2 meters, and the left eye, it was 6 by 18 parts, both of which were not improving on the best corrected vision. The color vision measured by the Ishihara chart was defective in both eyes. In the anterior segment findings, the lids, cornea, conjunctiva were well within normal limits. AC was well formed and quiet. Media was clear. Pupils, the right eye showed a grade 1 relative afferent pupillary defect, whereas left eye pupil was central, circular, and sluggish reactive to light. EOMs, extraocular muscle movements were full, free, and painless in both the eyes. Intraocular pressure taken at 11:30 a.m. with applanation tonometry was 14 mm of Hg in both eyes, and on gonioscopy, both eyes had open angles. In the media of both the eyes was clear. In the right eye, the cup to disc ratio was not well appreciated. Right eye showed grayish white disc with irregular fuzzy margins. The macula and fovea were well within normal limits. Foveal reflex was present. The blood vessels showed peripapillary retinal venous sheathing, and the periphery was well within normal limits as far as visible. In the left eye, again, media was clear. The disc showed mild blurring of the nasal margins. Optic disc failure was present. Macula was grossly WNL, fovea reflex was present. Blood vessels showed a normal AV ratio, and periphery was within normal limits. So these are the fundus photographs. As we can see, the right eye shows a grayish white pallor of the optic disc with fuzzy irregular margins, and left eye showing the nasal margins blurring and temporal pallor. So my provisional diagnosis after the clinical examination here is right eye secondary optic atrophy, and the left eye has disc edema suggestive of acute attack of optic neuritis. My differentials here are typical optic neuritis with multiple sclerosis, neuroretinitis, infectious or para-infectious optic neuritis due to bacterial, viral, or post-vaccination, inflammatory optic neuritis associated with autoimmune disorders like PAN, vaginous, SLE, idiopathic optic neuritis, and other differentials of disc edema like papilloedema, ischemic neuropathy, Foster-Kennedy syndrome. Investigations, we conducted brain MRI plus orbit plane plus contrast, color vision and contrast sensitivity, OCT RNFL, NMO and MOG antibody profile. Unfortunately, the patient could not go for the visual field testing, that's perimetry and visual evoked response. The MRI brain plus orbit plane plus contrast impression, the significant findings in that were noted as intraorbital segment of left optic nerve appears mildly bulky in size as compared to the right, and appears a hyper-intense on T2 weighted image and iso-intense on T1 weighted images, with mild effacement of perioptic CSF space. Mild post-contrast enhancement seen in the segment, possibility of optic neuritis needs to be considered. This is the OCT RNFL of the same patient. which shows thinning in both the sides, right and left. And this is the NMO and MOG profile that was conducted. Here it shows the MOG antibody serum to be MOG antibody profile to be positive. Then in the management part, patient was started.
I think you
Patient
can
was
stop here, Dr. Sneha.
Dr. Sneha. Okay. Yeah, Dr. Sumit, please go on.
So, Dr. Sneha, you can stop here. Because basically, we just wanted till the differential diagnosis and then go ahead. In case the mentors have any questions or any further things, then we will discuss about it. So, I think Dr. Ashwin sir can ask her questions based on the history. Ashwin sir, you need to unmute yourself.
So, can you hear me?
Yes, sir, I can hear.
Yeah. So, Dr. Sneha, I just wanted to know, your history was unilateral, painless loss of vision, right? In a young male.
Yeah.
So this loss of vision, which was acute, was in the left eye, I'm presuming.
Yes, sir.
Yeah. To summarize, I'm just saying. So has a left eye and right eye vision was less from before, and there's no new symptoms in the right eye right now. Am I correct?
Right, sir.
Okay. Right. And you have worked up the case quite well. It looks like we allowed you to go all the way up to your investigation. So it looks like you've done quite a few of the investigations already, and you've told us. You did make your. So can you repeat your clinical diagnosis again, please? Just go back to. So provisional or clinical, as you may say. Yeah. Go ahead. Yes. So you did find that there was a secondary optic atrophy right eye that looked very clear. And the left eye there was disc edema suggestive of acute optic neuritis. So what was your basis of calling this optic neuritis and not Foster Kennedy like a papilledema?
Sir, the patient gives a clear-cut history of similar visual loss complaints in the past. So we were thinking from the beginning that the patient has a bilateral presentation, which is asymmetrical and like asymmetrical and sequential progressing. And he also gave us the history that he was given treatment in the past for similar with certain injections and oral medications. And right
so
now,
history was suggestive of something recurrent.
yes.
But disc edema like papilledema can also be something that can be recurrent. So how would you, my point of my question is, how would you differentiate clinically a case of papilledema from optic neuritis? Like in terms of your eye findings, what is pointing towards optic neuritis in your case?
So, sir, papilloedema usually is a bilateral disc edema. And the most important thing with papilloedema is there is always a presence of raised intracranial pressure. Here in our situation, there were no findings or suggestive of raised intracranial pressure. There was negative history, in fact. And there was unilateral optic disc edema with other eye showing optic disc atrophy. So with the negative history,
like that is what it is, no, isn't it? That is where you will have one-sided papilledema, other side has optic atrophy.
Yeah,
so,
but there was no
else apart from no history of raised ICT. What else tells you that this is optic? You are right, Sneha. Okay, your provisional diagnosis is correct. I just want to know clinically what else have you found in your eye findings? Vision, color vision.
Yeah, of course. There is defective color vision in both the eyes. Right eye is even worse than the left eye on Ishihara plates. And the color vision has been defective. The patient says my color vision has been defective since a very long period of time. He also knows that.
And pupillary findings, can you tell me how that suggests?
Pupillary findings, the right eye is already showing relative afferent pupillary defect of grade 1, and left eye is a pupil. It's reactive to light, but it's sluggishly reactive.
So what is pupillary findings telling us more about? It is telling us about function of the vision, right? So we know right eye is optic atrophy.
Yeah.
So left eye pupil is also abnormal.
It's sluggishly reactive to light. There's a inflammation of the optic nerve sheath there, so there is.
That's correct. So unfortunately, this patient, although your acute eye is your left eye, right? It is your eye that he's complaining of. Your pupil is still pointing towards a right eye defect more so because that has significantly more optic atrophy. That is correct. Okay. So now, can you tell me, have you heard of the ONTT trial?
Yes, sir.
Yes. So tell me,
ONTT.
what is the clinical application of it? Just the clinical application.
Okay. So
Question, she knows everything is. Yeah, I'm muted.
Sorry, Himalini, you are not muted.
Okay, I'm muted.
Go ahead. Tell us, uh, tell us what you know about the ONTT clinical applications.
okay. So basically, ONTT trial is known as optic
Sneha,
neuritis.
Do you mind starting your video, please?
Yeah. 1 second, sir. I'll just.
So that way we can see each other. Yes.
1
If you
second.
don't
Can stop sharing also. if you
Stop
don't
sharing
mind.
the presentation.
Yeah, I mean, that you can do. Yeah. Only if you're okay with it. Otherwise, we can go on like this also. No problems.
Yes, sir. So
Okay.
ONTT trial stands for Optic Neuritis Treatment Trial. It was a randomized controlled trial which was conducted in which they divided the population into 3 arms. The first arm consisted of the placebo treatment for 14 days. The second arm consisted of low dose steroid, that is prednisolone 1 mg per kg per day for 14 days. And the third arm of group of people received intravenous high dose methylprednisolone 250 milligrams 4 times a day for 3 days, followed by oral prednisolone 1 mg per kg per day for 11 days.
So that low dose was oral, huh? Not just low, it was oral. Yeah.
Oral prednisolone. Low dose was oral prednisolone, the second arm.
Yes.
So basically, the purpose and objective of this study was to evaluate the efficacy and the adverse effects of corticosteroid treatment in the acute optic neuritis. Secondly, to study the natural progression of the visual loss and recovery in the acute case of optic neuritis, and to also study and establish the risk factors that are connecting the development of optic neuritis to multiple sclerosis. Those were the purposes.
Tell us the conclusion of the study.
Okay. So in the results of ONTT trial, the first thing that was noted is at the end of 6 months. So what they did is they checked the visual acuity, the color vision, the contrast sensitivity, and the visual field defects at baseline, and a few 7 follow-up visits within the 6-month period.
Results. Just tell us the conclusion.
Okay. So what they noted is at the end of 6 months, the people receiving the IV methylprednisolone group had a better outcome with the contrast sensitivity, color vision, and the visual fields than the other 2 groups. But at the end of 1 year, all the 3 groups had the similar visual outcomes. There was nothing different. Then another thing they noted is IV methylprednisolone accelerated the visual recovery in the first 15 days, and a near total recovery was noted at the end of 4 weeks. Then third thing they noted is oral prednisolone group and the placebo group did not have much of the significant difference in the visual parameters. And at the end of 1 year, all the 3 groups had nearly equal visual outcome. Fourth thing they noted is that the IV methylprednisolone receiving group, they had much significant lesser risk of developing clinically definite multiple sclerosis, which is basically observation of new onset neurological symptoms within after 4 weeks of entering into the study that lasts more than 4 weeks other than optic neuritis in either of the eyes. Then one thing more they noted is that the MRI was found to be a strong predictor of development of the multiple sclerosis if the MRI lesions were there. Then another thing,
MRI lesions at the time of presentation. There is at the first,
presentation,
at the first,
baseline.
at the
Yes.
baseline. Yeah.
And one more thing they noted, in the patients that had optic neuritis with no MRI lesions, there was a 5-year low risk factors that were there, which indicated that there is a very low risk of developing multiple sclerosis if the few factors were present, like very mild loss of vision, lack of pain, retinal edema, retinal exudates, disc edema, especially if it is severe, and peripapillary hemorrhages.
So Sneha, I think what you have done is you've missed one very important point, and actually that I would have expected you to tell me first. It is something that changed practice after ONTT was done. There was a change of practice. Prior to that, almost for 50 years or even more, that practice was going on. And then they changed that practice because of the ONTT trial. So what is that finding that you have not told me? If you can tell me, or I can just say it, no problems. If you can think of it within the next 5 seconds. So basically, they found that the patients in the oral prednisolone group.
Okay. Yes, sir.
So if they were only given oral
prednisolone, in fact, worsened the chances and worsened because of that the oral treatment, they had even worsening chances of recurring optic neuritis.
Absolutely. So although, to summarize, whether I give IV steroid or whether I give oral steroid or whether I do nothing, at the end of a year, they all have same vision. If I give IV steroid, I will get quicker recovery, but at the end of a year, it's not going to make a difference. But if I give oral steroid and only oral steroid, then I'm worse off than even no treatment.
No treatment.
So that was a change, a big change, because before that, they clearly knew optic neuritis responded to steroids, and they would give oral steroids primarily all around. So this was done in the US. So we are talking about US only. This was done in Caucasian eyes. Is there anything? The thing I would like to say here is this is done in the US, so done in Caucasian eyes, not in Indian eyes. One. Secondly, it was done purely for the typical optic neuritis.
Yes, unilateral.
So can you tell me what is typical and what is atypical?
Typical optic neuritis is the one that mainly the etiology behind typical optic neuritis is a demyelinating disease, that is multiple sclerosis, and all the other causes or etiology fall in the atypical criteria. So
you don't have that diagnosis when you're seeing a patient. Now you don't have a diagnosis. So how will you know yours is typical?
So there is a characteristic triad of symptoms. There is a monocular vision loss, sudden onset monocular vision loss associated with ipsilateral eye pain, associated with dyschromatopsia. The patient more or less lies in the profile of 18 to 45 year of age group, and more commonly frequently occurs in female. Clinically, if we see one more thing, the typical optic neuritis vision worsens like approximately up to 2 weeks. Following that, the vision spontaneously starts recovering, and there's a very good recovery at the end of 4 to 5 weeks, but the complete recovery can happen up to 1 year.
So that's good. So basically, being unilateral, painless, and recovery makes it typical. Very good. I think what we'll do is now have Dr. Bijlani take over and maybe create a discussion beyond this.
Thank you, sir, for that wonderful conclusion and the summarized version of the ONTT. I would like to welcome Dr. Rashmin, who has joined us as well. And since we were on the discussion of steroids, I had this question because we are in sort of a government setup where the MRI may take time. So my question to Dr. Himalini, Dr. Ashwin, and Dr. Ashwin as well: would you start steroids while you're awaiting the MRI results, or should we wait for the result to come in? Is it worth waiting for that day or two till the patient comes back to you?
No,
Sorry, go, Himani. Sorry.
I would definitely wait, Dr. Madhvi. I don't start steroids before I know at least the provisional MRI report. So very often what you could do is that send the patient for the MRI and write a note to the radiologist, or you could just call him and say that, look, when the MRI is over, could you please give me a provisional diagnosis? And if he gives you a provisional diagnosis where he has documented an enhancement of the affected side, the optic nerve, then I would start the steroids. I don't wait for the film, but at least I wait
Okay.
for the provisional report.
Okay.
No,
I think
what I
that.
was concerned about, Himani, just if you have a typical optic neuritis where you've got maybe not a retrobulbar but disc edema, typically shown with recent onset loss of vision. And like Madhvi said, you are in a government situation where you're letting this patient go away into an MRI where the patient may not be affording an MRI. I think all these things would I would admit this patient and do the first dose irrespective of whether I have the MRI. More importantly, I feel getting today, if you are, that is the first line of treatment for any optic neuritis, and it is a clinical diagnosis. In most cases, the typical form at least. I can understand if you've got some atypical findings and you are not sure this is optic neuritis. So I would, in those cases at least, definitely give the first dose, and then you're waiting for the next dose. You can even do one large dose, although you can break it up into 4 doses or 2 doses, whatever. Yeah, I would do the steroid market.
Okay. And also another question would be, how soon should we involve a neurologist in the management, whether it's typical or atypical? Like as soon as you've diagnosed it, or probably give the IVMP, and then what would you all recommend?
So I involve the neurologist from day one. I mean, it's a teamwork. There is a radiologist and there's a neurologist who I closely work with. So moment I've diagnosed the optic neuritis, the ball is set, on a roll, and you get the MRI done, provisional report, start the IVMP, finish the 3 or 5 doses, whatever you depending upon how the severity of the loss of vision, and then you wait for your markers to come. And the meanwhile, you send the patient for a cross to a neurologist. So I involve the neurologist right from day one.
Rashmin?
Yeah.
So I think one point on this discussion, and if with your permission, I would like to ask a few questions to our presenter as well. So I agree with Hema. We need to remember that optic neuritis is a neurological disease with a manifestation which has come in the vision. So it's not really a disease of the eye. So our job in optic neuritis is to confirm that it is not really a uvea or retina related acute loss of vision. Do the optic nerve function test, which will include OCT now, because that seemed to give some prognostication and a larger state. There are a lot of AI algorithms which are coming up, which might guide you to say that maybe we are dealing with NMO or MOG, and maybe in a couple of years we'll have even that kind of indicators. And I agree with both Ashwin and Hema that neurologists should be part of this, because please remember that as Ashwin was mentioning, that an atypical optic neuritis, a large part of atypical optic neuritis in our practice would be antibody-mediated optic neuritis. And 2 antibodies that we are aware of right now is NMO and MOG, with some GFAP-related material coming in now. So especially NMO-related optic neuritis, there is more and more evidence that plasma exchange early in the disease probably prevents a neurological disability. And that obviously has to be done in a neurological setup. So that's the reason why neurology has to be involved. With permission, couple of exam-related questions to Sneha. Sneha, why you didn't see RAPD in the left eye?
So RAPD.
Did the patient have bilateral RAPD? Did the patient have bilateral RAPD?
No, sir. It's a relative afferent defect. It's appreciated in a in one eye only. So right eye showed grade 1 RAPD.
Make That's a basic thing saying RAPT is a relative afferent pupil defect. So there is no such thing as bilateral RAPT. Either there is a sluggishly reacting pupil in both the eyes if there is a bilateral symmetrical disease, or there is a RAPT if there is a asymmetrical disease. And we had a very nice discussion. Ashwin was actually guiding you towards a difference between Foster Kennedy and a pseudo Foster Kennedy. Foster Kennedy, you need to remember, the eye with the disc edema will have optic nerve dysfunction. Optic nerve would be normal. Pseudo Foster Kennedy, eye with the disc edema would have optic nerve dysfunction. Getting Foster Kennedy, the eye which is which has an atrophy is because of compression. An eye which has an edema is because of papilledema. And papilledema generally would not have an optic nerve dysfunction in the early stage. And a pseudo Foster Kennedy syndrome, the eye with disc edema is because of an optic nerve swelling. It's not really a passive edema. And they will have an optic nerve dysfunction. Yeah, sorry.
I'd like to add a point, Dr. Sneha, when Ashwin asked you the difference between, why your case was optic neuritis and not really papilledema. So just a pointer there that when you see disc edema and the vision loss is as severe, but your disc edema was very mild, that is more towards neuritis. But when you see like a papilledema, your disc edema will be really florid, with a blown up disc, with dilated tortuous vessels and lots of hemorrhages. But the vision loss will barely be like, like you'll have like 618 or a 612 with that kind of edema. So that is another clue that you could keep in mind.
Yeah, just one more thing while we're on the pupil, which could be a common exam, tricky question, is in a situation like this where you have reduced vision and significant pallor in one eye and not in the other. So did your patient have anisocoria? Anisocoria is, tell me what anisocoria is first, then answer that question.
Difference in the size of the pupils.
Very good, very good. So tell me, did your patient not have anisocoria?
So it was not very significant.
Okay, so that's a trick question. Okay, so it's your patient. So when you have an afferent defect, which means your optic nerve is affected, your consensual is equal to your direct reflex. Means each eye is stimulated by a direct and a consensual. So you can never have an anisocoria when you have cranial nerve 2 affected. Okay, your pupils will be equal always. Only an even defect will give you anisocoria. So your answer should be no, there was no anisocoria.
No anisocoria.
Been a little. Okay.
Okay, I think due to interest of time, we'll move on to the next case. This has been a lovely discussion. Dr. Saili, could you please share your screen and start your case?
Good evening, everyone. Happy Teachers' Day to everyone who's present. I hope I'm audible and my screen is visible.
Yes, perfect, Saili. You can start.
So today I'll be presenting a case of a 27-year-old male who presented to the emergency department with complaint of severe headache since morning after waking up. This was associated with 2 episodes of vomiting and with drooping of right eyelid since afternoon and outward deviation of right eye since afternoon. Coming to past history, he did not have any known comorbidities. There was no history of fever or weakness of limbs. There was no history of trauma or ocular pain. There were no history of similar episodes in the past, or he was not on any medications. There was no history of weight loss as well. His personal and family history showed that he was not habituated to alcohol. There was no history of drug abuse or tobacco consumption. His bowel bladder were normal. There was no significant family history as well. His general and systemic examination was within normal limits. His cranial nerves and neurological examination did not show any significant differences. Coming to ocular examination, head posture was straight. He was orthophoric. There was no facial asymmetry. I would like to present my right eye findings first. His vision was unaided 6-6 parts, best corrected 6/6. He read all 21 plates of Ishihara plates. Hertel's exophthalmometry showed 21 at a base of 98. Eyelid showed complete ptosis. There was restriction of all ocular movements except for abduction, and on forceful adduction, intorsion was noted. Eye was in exotropia and hypotropia. On confrontation test, we found left hemifield restriction in both eyes. Pupil was round, regular, dilated, not reacting to direct or consensual light. His conjunctival cornea, anterior chamber and lens examination was within normal limits. Corneal sensations were intact. Intraocular pressure was 10, which was normal. Ice pack test was negative. All the left eye findings were within normal limits. Coming to fundus examination, as we can see, there was bilateral disc edema, which was more in the left eye than right. Disc margins appeared blurred in both eyes. The physiological cup was obliterated. Appearance was hyperemic. Vessels appeared obliterated and venous tortuosity was present. The AV ratio was 1:2. So my clinical diagnosis is bilateral disc edema with right third nerve cranial palsy involving the pupil. We investigated him further. Here is OCT that shows bilateral disc edema. We did a perimetry on octopus in G dynamic, which showed macula staring left homonymous hemianopia. These are my differential etiologies, which would be an aneurysm, ischemic stroke, cerebral venous sinus thrombosis, AV malformations, primary brain tumor or metastasis, or undiagnosed hypertension or diabetes mellitus. We did do a CT to know the cause. It showed a posterior communicating artery aneurysm with a possible rupture as shown by the red arrow, leading to a subarachnoid bleed in the basal and paracellar cistern. There was also a moderate to large size posterior cerebral artery territory infarct on the right side. Sorry. So coming to the diagnosis and pathophysiology of the same, aneurysm in such a young patient could be due to an undiagnosed connective tissue disorder.
Dr. Saili, can I stop you there and we can take some questions from Dr. Sumita?
Sure,
Then
ma'am.
go ahead, maybe.
Yes, ma'am.
Sumita, ma'am.
Good evening, everyone. All the panelists, Dr. Sumit. A very nice discussion going on. Dr. Saili, nice presentation. Can you tell me the causes of bilateral disc edema which you saw in this patient? What comes to your mind first when you see bilateral disc edema? What are your different?
Yes, ma'am. So we can divide the causes of bilateral disc edema based on etiologies. It can be due to raised intracranial pressure, which can be due to idiopathic intracranial hypertension or any space occupying lesions such as tumors or subarachnoid hemorrhages or metastasis. It can be due to an hypertensive emergency such as malignant hypertension. It can be due to toxic or metabolic causes such as methanol poisoning, B12 deficiency. It can be due to infiltrative conditions such as sarcoidosis, lymphoma, leukemia, infections such as syphilis, Lyme's disease. It can be due to hereditary or mitochondrial conditions such as Leber's hereditary optic neuropathy, or due to inflammatory causes, or due to autoimmune etiologies such as NMO and MOG antibody disorders.
When you see this bilateral disc edema, what are the ways that you can classify or give a scale to them? What are the different ways that you grading? What are the different ways that
Yes,
you can
ma'am.
grade
So,
them? And what is the utility of such grading?
sorry,
Why
ma'am.
do we need to grade them?
So, ma'am, we need a grading to differentiate between the severity of papilledema and to know if there is any improvement after treatment. Most commonly, we use the Frenzen scale in such cases. It is divided from grades 0 to 5, grade 5 being the most severe. Grade 0 is no papilledema. Grade 1 is minimal or very early papilledema, in which we can see a C-shaped halo around the disc in which the temporal margin is spared. In grade 2 or early papilledema, there is a circumferential halo around the disc and the RNFL fibers appear prominent. In grade 3 or moderate papilledema, we can see that the disc edema becomes more prominent and there is some obscuration of vessels that are around the disc margin. In grade 4 or marked, sorry ma'am. In grade,
Yeah, continue, Sai.
yes ma'am. In grade 4 or marked papilledema, there is prominent elevation of the disc appears swollen and congested, the vessels are obscured more than one. And in grade 5, which is severe papilledema, there is severe swelling and elevation, hemorrhages and exudates can be appreciated, and the physiological cup is completely obscured.
So it's almost a newer classification, which really helps to decrease the inter-observer variability also. And
Yes,
you know, there was an older classification also. That was also used in the past before this recent state was used. Something like early established, a tooth fake. Any idea about that?
yes ma'am.
Okay, let's go to the next question. So next, then you saw the third nerve palsy
Yes,
associated
ma'am.
with. So you had a pupil sparing or pupil involving third?
It was a pupil involving third nerve palsy in our patient, ma'am.
Why is it important to differentiate whether it is sparing or involving?
So, ma'am, I would like to discuss the anatomy of third nerve for this. So, in third nerve, there are two kinds of fibers. One is parasympathetic and other is somatic motor fibers. The somatic motor fibers occupy the central part of the nerve, whereas the parasympathetic fibers that supply the pupil occupy the peripheral part of the nerve. So the lesions which are compressive in nature will, such as tumors or aneurysms, will uh, first compress over the peripheral fibers that are pupillary fibers, and it will affect the pupil, causing dilatation of the pupil. And when the etiology is vascular, such as there is any microvascular blockade or diabetes, hypertension, it will target the central somatic motor fibers, as the peripheral fibers have their own supply. So this will be pupil sparing. And ma'am, conditions such as tumors and aneurysms, which cause a pupil involving third nerve palsy, are much more clinically severe and need immediate clinical interventions.
Yeah, that's right. To see a pupil sparing one, you can still, you know, the aggressiveness, because we know it is more associated with systemic disorders. Your approach can be a little less aggressive, but if it's a pupil involving, you definitely have to be more aggressive in your investigations, finding the cause and then treat.
Yes,
Dr. Madhvi, you can.
Yeah. Yes, thank you, Dr. Sumita, for that discussion. I have one quick question for the panel. Since she's discussed papilledema, we have some patients who present with headache, papilledema, but it's because of a cerebral venous sinus thrombosis. So while we are differentiating these two, would you go ahead and advise a CT scan or an MRI for such patients in an acute setting?
You mean to say that the patient has presented with a bilateral papilledema and
with headache, like in a young age group, you're like, could it be this or that?
yeah, so what I generally do is again communicate with the radiologist, tell him what the history is. Why I'm driving this point again and again is that most of the times that when we send patients for neuroimaging, we fail to do that. So it is a good idea to communicate with your radiologist. I would get an MRI, and if the MRI was normal, I would write a note saying that if the MRI comes normal, please go ahead and do a venogram.
Okay.
So I wouldn't do a CT.
In either of the situations,
unless there was a third nerve palsy like what this patient
Okay.
had, and if the patient had lack of funds, then at least I would have got a CT angio done.
Okay.
But that's because this patient had a third nerve palsy.
But if it was purely disc edema, you would have still gone ahead with an MRI.
A venogram.
Venogram.
The role of CT scan is only when the MRI, as Hema was mentioning, when the patient has papilledema, and your first job is to make sure that there is no space occupying lesion, which can be a tumor or hemorrhage or whatnot. Now, MRI is investigation of choice because in the same setting you can do MRV. Rarely now the neurologists have started doing MRA as well. But if patient says that MRI cannot afford or the date for MRI is not available or whatnot, then at least a CT scan to make sure that there is no space occupying lesion, but that's not the first choice.
Okay, thank you for that, sir. Another question I wanted to ask is when we have a lot of these MRIs with papilledema and the report says empty sella, like this is in interest of all the ophthalmologists. How often is this really significant for us, and when can we choose to sort of ignore it?
So empty sella is one of the supposedly adjunct features of raised intracranial pressure. So now you are already suspecting that patient probably has papilledema. You did your neuroimaging and your diagnosis. I mean, if you had done a neuroimaging because patient had a unilateral loss of vision, if there was an empty sella, obviously you ignore it because it can be a finding which can be present. But is that finding contributory to what patient is having? Would be if the patient already has, you suspected intracranial pressure, raised intracranial pressure. There are three most important radiological features that you should be on the lookout for. One, widening of periocular spaces, which is best seen on coronal scans, empty sella, and the flattening of the globe because of the pressure, the flattening of sclera. So if empty sella present and you are already suspecting raised intracranial pressure, it assumes significance, saying it is only reinforcing what you were suspecting. In the presence of now the difficulty comes in, I mean, practicing difficulty, not for the exam for you, is where you had a little hyperemic disc. Patient is complaining of headache and you did MRI because of headache. And now you're stuck with empty sella, while you were not really very sure about when you have headache and empty sella, you go back and see now and you say, oh, maybe there is hyperemia of the disc, is where now you don't know whether empty sella is significant or not significant. Generally, what I do is that if clinically, because as an ophthalmologist, now, as Hema has been saying, we are just one part of the treating physician team of this situation. So I would have done from my side, I would have done the optic nerve function test, which would include HVF and OCT. If I was really saying that, yeah, there is a little bit of axonal swelling, I'll call the patient back in a week's time. If the Humphrey visual field is fine, color vision is fine, there is no optic nerve dysfunction. From our side, to confirm whether are we dealing with very early papilledema, OCT and the clinical picture will help if you do it a serial monitoring. So patient comes back, and if you have a clear increase in RNFL on OCT or on clinical picture, you know that you are dealing with whatever you observed in the first setting was significant. But if it remains static, at least from our side, we don't have to deal with.
Okay, yeah, that makes sense. Thank you.
Dr.
Ashwin?
Saili, sorry, Dr. Saili, can you stop sharing, please? And then
Yes,
we'll
sir.
go ahead. Yeah. Yeah,
No,
Madhvi, go ahead. Yeah.
Yeah, Dr. Ashwin, would you like to add something to that?
Second, what Rashmin said, I think a lot of patients with the doubtful nerve, the serial sort of OCT turns out to be very helpful because you know you've got no optic nerve dysfunction, and sometimes and a true papilledema will either get better or worse in 2 to 3 weeks. So if you have nothing happening on a serial, you feel more confident to inform the neurologist that listen, no need to start the Dimox or just keep it. Yeah. It's probably pseudopapilledema.
Thank you, Saili. That was a lovely case by you again. And I'll quickly share two scenarios that I had just to complete the discussion.
Meanwhile, can I just insight one?
Yes, sir, definitely.
This is for all panelists. Now, okay, this patient, and lovely case, Ashwin. I mean, this actually emphasizes our role, that patient coming with third nerve palsy. This patient had bilateral papilledema, but if patient came a previous day and patient had a third nerve palsy, and if you missed advising CT scan or MRI scan that day, and then patient developed a subarachnoid hemorrhage the next day, I mean, that's a clear emphasis here that a pupil involvement in a third nerve palsy is a medical emergency, and you need to act on it fast. What about a third nerve palsy? And I know that there was a little bit of discussion on that. Patient with a third nerve palsy, and no involvement of pupil. What is your clinical practice? This is not for you exam going students, but clinically, what would you do?
I would
So,
still, you go ahead, go ahead.
no, I mean, you're saying no neurological deficit, no other neurological deficit, and this is a young patient, you're telling me, or
65,
any?
65-year-old patient with a no involvement of pupil and a third no palsy.
So I would still put the patient, would probably not be in such a rush to do an imaging, and I would still put the patient through a physician's workup for the usual blood pressure, lipid profile and everything. But I would watch them more closer to wait for, just look for possible pupil involvement or possible change in whatever we're seeing. And if I don't pick up any other cause and there is no recovery or it's getting worse, I will watch them closer, probably 2 weekly or 10 days and yeah, otherwise doing an MRI sometimes also depends on what type of patient you're seeing and how agreeable he is to have it.
Yeah, we can,
Ashwin, I would differ in the sense that, third nerve palsy, whether the pupil is involved or not involved, is definitely an emergency. If there is paucity of funds, I would definitely just get a CT angio done at least. But I would not defer the angio. Where the pupil no longer is relevant to me.
Madhvi?
I would agree more with what Dr. Ashwin does because I'm working more in a government setup. I will order like a blood profile first, try to rule out if there's any systemic thing associated with it. And if everything is inconclusive, definitely push for imaging or wait and watch for a bit at least.
Dr. Sumita, what do you know?
Yeah, I was saying the same thing because we are in a charitable and we do get many patients who are referred from medicine. They are known diabetics and they land up with this third nerve ptosis. So we just keep them on a follow. We don't really subject them to MRI. We keep a close follow up if things are changing. If it is worsening, people is getting involved, then we move it.
So there are 2 points. This is a really hot point, and I think nobody is right or wrong. A lot of practitioners now are opting to just get the neuroimaging done, even if there are no signs of a compressive lesion, only because they fear what we are missing out is much more sinister. So what you are actually, but in our practice scenarios, it's very difficult to sometimes convince patient that while you're not at a risk of any compressive lesion of third nerve, but I would still like to rule out. So the point for the postgraduate would be in the exam, if you're asked, and Ashwin answered it, saying that please remember 86% of the patients who develop third nerve palsy because of PC aneurysm would have pupil involvement on presentation. Flip these numbers aside, the numbers are then that 14% of them would not have involvement of pupil, though they have aneurysm going on. So these patients, if you are not going to do neuroimaging, make sure that you don't let them go. You look at the patient's pupil very closely every weekly to begin with, to make sure that pupil is not getting involved little later in the disease. So there is, as I said, there is no right or wrong answer. My personal practice is that if patient is affording, if there are no logistical issue, I would go ahead and do neuroimaging. But if patient, if I'm not able to request for neuroimaging, I'll follow it up very quickly.
So can I just say, whatever you said, Rashmin, I'll just drive that home. You're right. This patient of ours obviously had the aneurysm sitting in his head for a while. It was a ruptured aneurysm that led to the third nerve, actually. So he had an aneurysm fairly large, but not presenting with a third nerve. And the day he had the rupture, there was a thunderclap of a headache. That's how they described it. And that was the ruptured aneurysm that led to the subarachnoid hemorrhage, that led to, in fact, a hemianopia, which was a good finding in a patient like this, because he also had a posterior cerebral artery. But so he sat with an aneurysm and no third nerve, and it was the hemorrhage that caused it. So yeah, you can have an aneurysm without any affection of people. You surely can. Yeah.
Thank you for that insightful discussion. And I'm quickly going to just show these few images that I wanted to discuss since we've already had case discussions. So this is a 10-year-old male who came for a routine eye examination. There's no significant history. And his examination was stone cold normal, the vision, color vision, pupils, anterior segment, everything. And then we went on to see the fundus, and this is what it looked like. So like we were discussing earlier, it's an asymptomatic patient. You're seeing blurred disc margins. So this was basically for the postgraduates to, so would you like to start the discussion about pseudopapilledema and how they should investigate, or what should we do next? Dr. Rashmin?
Oh, sorry.
I didn't get that. Yeah, sorry. So fascinating. Again, one, asymptomatic, but that doesn't really mean anything because papilledema can have a normal optic nerve function. Two, clinically, the most important feature is look at the blood vessels on the surface of the optic disc, especially the medium-sized vessels. If you can see those vessels clearly on the surface of the optic disc, you know that there is less likelihood of a fluid there or an axonal swelling. So clinically, look at the medium-sized vessel, and when present or absent, the spontaneous venous pulsation. In this patient, if you can see, there is a little AV malformation in the left eye. So when you have small discs with some of these vascular abnormality, you know that maybe you are dealing with a pseudopapilledema. And optic nerve function test, yeah.
Yeah, so I've just put up some pictures of an OCT with it, because if you're unsure, you could probably go ahead and do that. Or I think some practitioners even do a B scan to sort of rule out the drusen. I had seen a patient who even went ahead and he had a CT scan as well, which showed the same thing. But I don't know if we should go up to that extent, or our clinical acumen should be okay to judge it before we reach the imaging part.
Again, serial OCTs. And I think there are some features in the OCT that tell you, especially this after shadowing.
Yes.
Although it's not very accurate, I mean, this has been described, but I cannot really make those diagnoses. I see this even in true papilledema at times. Essentially, the drusen is not allowing the scan to go beyond, and there is an after shadowing that you can see behind the drusen. So I would trust a serial OCT.
Plus fields, the perimetry will give you a clue, because you do, and the perimetry is normal. So, you know what.
Papilledema, how accurate is your enlarged blind spot? Like, I mean, sometimes I feel that I cannot make that judgment, especially if the papilledema is not your grade 4, grade 5. Then I can't really say that the blind spot is that large.
Yeah, so there are 2 points here. I mean, like if you have an access to OCT, serial OCT, B scan, you will find even hyperechoic shadow, which will persist even if you reduce the gain. I mean, that's because of the calcium which is present in the optic nerve drusen. And if you don't have access to these two, I mean, then visual fields, as Hema mentioned, please remember occasionally, even the drusens, not in this age group, but a patient who is at the age of 30 or 40, even a buried drusen or a drusen on the surface of the optic disc can give rise to few visual field defects. However, enlarged blind spot is much more common in papilledema than in drusen. Now, if you're not very sure, as what Ashwin mentioned, that it's not an impressive enlarged blind spot, one other factor to look at is mean deviation. Now, if you have a mean deviation which is, let's say, positive, you know that maybe patient is all right. If you don't have an access to OCT and ultrasound, repeat the visual fields and look at the mean deviation. Now, if you have a reduction in mean deviation, that's a good indicator that there is something going on in the optic nerve. Now, I mean, not in papilledema, but in patients who have an optic nerve disease. And if you have, even in papilledema, not in differentiation between papilledema and pseudopapilledema, but if you're dealing with a full-blown papilledema, and if you have a mean deviation of minus 7, that's almost like you're saying that the papillomacal bundle is really getting wiped out. And that is one of the indicators of you being aggressive in treating that patient.
Right, right. That's an important pointer. I think the mean deviation or the perimetry. Okay, and the next one is actually okay. This is just about Brussens, more of theory. The next case is a sort of, I'll give away the diagnosis, typical optic neuritis, a 27-year-old female with sudden onset DOV with pain on eye movements, no other significant history. She comes to you with reduced vision, color vision is abnormal, and she has an RAPD. So unfortunately, Dr. Sneha couldn't include scans on her presentation because she said her patient did not have them. So I just thought we could start a discussion about the radiological findings, especially in multiple sclerosis, because this could be asked as an exam spotter to the PGs as well. So Dr. Himalini, could you please share some points on that, how they could identify?
So you typically see hyper intense lesions, and the radiological picture is classically described as Dawson's fingers. If you have that classical one, the location is very typical in multiple sclerosis. That means you'll find them only in periventricular. So these are some of the clues. Okay, and just one thing here is that if you see demyelinating lesions for the first time, does not necessarily mean that your patient has multiple sclerosis. So there's something called as McDonald's criteria. So let's say the patient has got optic neuritis, you find these lesions, you've treated with IVMP, don't label him as optic neuritis. He's probably got a clinically isolated syndrome. To definitely say that he has clinical, definitely multiple sclerosis, you have to use the McDonald's criteria, where you have to define the lesions in terms of space, in terms of number of lesions, and in numbers of time of dissemination. So time, space, and number.
Absolutely. I mean, what you see, these white spots, they just indicate that there's a demyelination. Please remember, infection can also lead to demyelination. Some of the viral infections can lead to demyelination. So yes, presence of demyelination does not really confirm that the patient has multiple sclerosis. However, where you find these white spots, the demyelination may give you a clue, like what you have here, Madhi's pointer. I mean, that's sort of a very typical Dawson's finger. So if you're given an MRI, this is for postgraduates, and if you are in the setting of, if the history is suggestive of optic neuritis, you need to look at the optic nerve, which is better seen in an axial section where you see here, and then look at the area of the brain. In the optic nerve, you need to look at the hyperintensity, especially in T2. You need to, if possible, figure out if the hyperintensity is more anterior, is it only in the orbit, or is it extending towards chiasm or optic tract. So white lesions, which is hyperintensity, better seen on T2, whether it is restricted to only within the orbit or is it going out of the orbit. Why this is important? Because a lot of our patients in Asian population may not be having what is described in literature as a typical optic neuritis, but they have a antibody-mediated optic neuritis. And for them, the hyperintensity would extend up to chiasm or even optic tract, especially in NMO. Also, if you find that one nerve, and so one clue would be the nerves would appear different. Even if you don't know whether it's hyperintense or not hyperintense, you know that these two nerves are appearing a little different. The other feature to look at is the nerve thick? If there is a thick nerve all throughout, which is also called perineuritis, this is not very significantly thick, but much thicker nerve, then you know that maybe you are dealing with MOG. So MOG has perineuritis, NMO-related optic neuritis, you have an involvement of the chiasm and the optic tract. So yes, you look at the hyperintensity in the optic around the optic nerve, and then the areas. For multiple sclerosis, you are looking at the periventricular areas, as has been seen on the third picture there. So periventricular areas is where you have the intense lesion and also around the corpus callosum. While in NMO, typically these areas may not lit up so much. You may have involvement of hypothalamus, area postrema. The typical feature is area postrema syndrome, and the symptom to ask for is persistent hiccups and vomiting.
Thank you. That was helpful. But I have one final question for the panel. How often would you advise a cervical spine screening with your MRI whenever you advise it for an optic neuritis patient? Would it be for all of them, or if only if you're suspecting atypical?
I don't order a cervical spine MRI, even if it's atypical and if I've got the MOG and NMO positive, as long as the patient doesn't have any symptoms, spinal, symptoms, I don't order a cervical spine. And I leave that option to the neurologist, actually.
Okay.
So I know we had this discussion in one of the meetings recently, and Dr. Veena Norona from Chennai, she had mentioned that she generally she does the screening. She's a neuroradiologist, and she does the screening from the history that she gets from the physician who has referred the patient. So I also don't do it routinely. Obviously, as Hema mentioned, this is more in the purview of neurologists. But the information that you would like to share with either neurologist or radiologist would be: patient has a profound visual impairment or a bilateral involvement, or patient has a significant disc edema. Now, if you know that these features are already pointing towards atypical optic neuritis, and that means that you're not really dealing with multiple sclerosis or what is described as a typical optic neuritis, but something else. And these are the patients where probably a spine screening, apart from antibodies, may be necessary.
Okay. Yeah, that sounds good. So I think we've had a really very nice discussion, not only for the residents, but even the clinicians attending. I've got to revise my neuro as well. So thank you so much to our panelists, mentors, and the postgraduate students who have taken some great efforts to present these cases. All the very best for your exams. Thank you, Dr. Sumit, and all of MOS for having us here today. And happy Teachers' Day once again. And good night. Thank you so much.
Thank you. Great presentations and lovely discussion. We also thought Happy Teachers' Day.
Happy Teachers' Day.
Bye. Happy